A very good morning to all of you. After Meenakshi Sundaram sir's impressive, informative and enlightening talk, let us go to measuring and monitoring of perioperative patient safety. What is patient safety? It is avoidance, prevention and amelioration of adverse outcomes or injuries during the process of healthcare. Of course, it's a shared responsibility or it's a collective responsibility of all the professional groups involved in the perioperative process. It includes healthcare system, healthcare workers, patients and their families also have this responsibility. Why safety in hospital? We know hospital always operates under continuous stress and strain. This gives rise to some irritation, aggregation. It can threaten the life of staff as well as it can cause damage to the properties. It can cause loss of faith for the patients on hospital. As anesthesiologists, we have workload, production pressure, financial problem. Nowadays, we are dealing with more and more of older and sicker patients. That itself can contribute to stress to the anesthesiologist. How dangerous is our healthcare? WHO reports 10% of the patients are harmed during the hospital care. In a systematic review and meta-analysis, 20% of the surgical patients during their hospital stay and 34% of ICU patients were harmed during the hospital stay, out of which half of these harm were preventable. In a modified critical incident analysis technique on preventable anesthesia mishap, they show that human error contribute to 82% of the mishap with breathing circuit disconnection, inadvertent changes in the gas flow. But this article was published in 2002. And now the practice of anesthesia has become safer and complications and poor outcomes are now rare. Anesthesia can contribute to overall perioperative risk. What are they? It can contribute to infections, respiratory infections, neurological complications, cardiovascular complications, thromboembolic complications, and all these complications can contribute to surgical mortality. So, our hospitals at the local system and the organization should develop guidelines using a team approach to ensure optimal patient safety in the OR. A framework for measuring the quality aspects in healthcare that was proposed by Donna Badian in years back, and this was even mentioned in Miller, that is widely accepted one. He gives emphasis to structures, process, and outcome. Structures means the physical and organizational setting in which healthcare is delivered. That means healthcare facility, the personnels, equipments, and so on. Process means how we diagnose the disease, how we treat, what about the patient's awareness and education. Outcomes. Outcome is the effect of healthcare on the patient. Now, types of safety, we know Sir has sometimes, some minutes ago mentioned about medical safety, surgical safety, electrical safety. Now we will go to equipment, environmental safety, blood and lab safety. Dr. Krishnan will be elaborating in the coming lecture. Now, if you cannot measure it, you cannot prove it. So, improving patient safety requires some tool or some instruments to measure it. But there is no generally accepted perioperative patient safety indicators. We know patient safety, it is here we are measuring the quality of care. It is not a quantitative measure. It's a non-quantitative construct that we are measuring. 4 measurement methods are described in literature. One is incident-based learning or incident-based measurement. Then rate-based learning, staff views and patient views, or staff survey and patient survey. About incident-based learning, that is case-based approach. You can describe, the frequently occurring atypical problem, also rare and potentially serious problems can be described by case-based approach. Here we are collecting the data on a qualitative basis, and this report can be disseminated within the professional groups in your city branch, then to the state level, like that. And you can get information on case-based approach from the morbidity and mortality conferences, incident reporting system in the hospital, etc. Then what is its significance? Here, after getting an analysis using structured protocol and root cause analysis, that will reveal what is the local system weakness in that case. That allows us to find the solutions for that also. If an incident is frequently observed or if it is repeating, safety indicators can be developed at the local level. Then limitations, we know it is not a quantitative measure. It has limited generalizability. There is no denominator for the measurement, so you cannot calculate the rate and trends to which population you have to apply. That is not mentioning. So risk of barriers, risk of underreporting, some site of hindsight bias. It's a psychological phenomenon. Here, after the incident has happened, we ourselves will try to convince others that the event he has already accurately predicted. ഒരു സംഭവം നടന്നതിന് ശേഷം പറയും ഇത് ഞാൻ ഓൾറെഡി ഇത് പ്രെഡിക്റ്റ് ചെയ്തതാണ് എന്നുള്ളവർ. Now, rate-based learning uses quantitative approach. Another one is rate-based learning. It's a quantitative approach to measure and monitor patient safety. Here, the data is collected prospectively and routinely according to quality indicators like surgical site infection at 30 days. What is the incidence of stroke in ICU? Like that, you can collect prospectively. That can be used for data analysis. Here, there is a population, you have a denominator for that rate. So you can calculate the rate, you can analyze the trend also. What was the infection rate in the last month, like that. Significance, surgical outcome reporting, it can significantly impact the morbidity and mortality. It is a quantitative measurement. Limitation, we know there are no gold standard set of indicators. It's a slow reporting process. Underreporting and barriers are some of the limitations. Some of the safety indicators are, so already mentioned, surgical site infection at 30 days. What is the stroke within 30 days? What is the death within 30 days of CABG? What is the length of hospital stay? Like that. Then regarding the staff survey and patient survey. Staff survey is a subjective view of healthcare professional. Healthcare workers and professionals are different. Healthcare professionals are giving healthcare based on evidence-based medicine. Here we are collecting the data on a quantitative base. Limitations is survey tool validation. One example is safety attitude questionnaire. Here we are giving questions on 6 different domains. Regarding patient views on patient safety. Here, outcome that matters to the patient, and we need sufficient time to talk with the patient to understand about their views. For that, as Meenakshi Sundaram sir has already mentioned, you should be a patient-centered doctor. You should, they will contribute to the adverse outcome and attributing factors. You should give due respect. You should give care, and you should be a patient-centered doctor. Example, patient measure of safety questionnaire. Then, what is its significance? It provides an important learning opportunities for us. It enables shared decisions while taking consent, while we are explaining the procedure, they will give their decisions on the case also. Then you can improve patient satisfaction. Limitations, there are barriers for that. Illness severity, cognitive impairment, communication-related factors, language barriers are the limitations for these views. Now, you can apply PDSA cycle model after getting this rate-based learning, incident-based learning, staff views and patient views at the local level as well as on the general level. Plan, do, study, act. It has been mentioned, it is mentioned in Miller also. After getting patient's views, staff views, rate-based learning, and incident-based learning, you can develop protocols, standard operating procedures you can detect, you can develop. Then hospital department, quality reporting system, incident reporting system you can give. Then you can give it to regional level, other hospitals, registries, then formal research projects, international literature. Then you can develop guidelines and recommendation. Thereafter, you can share it to the local level. Now we will discuss surgical safety checklist. I know most of the private hospitals and in Kerala itself is practicing this WHO safety checklist in the OR. What we have to do before the induction of anesthesia? You should identify the patient, site of procedure, whether the consent has been taken. Is the site marked? Is anesthesia machine and medications checked completely? Is the pulse oximeter there on the patient? Whether it is functioning? Does the patient has a known allergy? Are you anticipating difficult airway or aspiration risk in this patient? Is there a risk of more than 500 ml of blood loss for the procedure? Then timeout procedure with the nurse, anesthetist and surgeon. Confirm all the team members have introduced themselves before the procedure by name and role. Confirm patient's name. Then whether antibiotic prophylaxis has been given within the last 60 minutes. Then you have to ask them, are you anticipating any critical events, to the surgeon, to the anesthesiologist and to the staff nurse. And essential imaging has been displayed. Then coming to the sign out, before patient leaves the operating room, the nurse can verbally confirm the name of the procedure, completion of the instrument, specimen labeling, and to the surgeon and anesthetist and nurse, you can ask, what are the key concerns for the recovery and post-op management of the patient? So we have discussed timeout, that is to perform correct procedure on the correct body part of the correct patient. If multiple surgeons are involved in the team, clinical team leaders are responsible for verifying the details of the portion of the operation. All relevant records, images are to be displayed, and if any part of the verification process is incomplete, OR activity should be halted. Patient safety strategies in anesthesia. According to ISA guidelines, you can get a preoperative assessment and optimization. After optimization, you can get an anesthesia plan for the patient. Then A, B, C, D, airway equipment, breathing system, suction, D, devices, drugs, defibrillator, E, emergency medications, cut. You should have a reliable source of oxygen with backup supply. Check backup equipment, rapid reassessment in case of any abnormal vital signs are there. Assess patient's risk and document it. All of us know the standards for basic anesthesia monitoring, standard 1 and standard 2. Standard 1 is continuous presence of a qualified anesthesiologist throughout surgery. Standard 2 is both has objectives. Standard 2 is patient's oxygenation, ventilation, circulation and temperature should be continually evaluated. Briefing and debriefing, that should be incorporated into institutional culture. We have already mentioned about briefing and debriefing at the personal level, at the patient level and planning level. Is there any improvement at the personal level? What complications and incidents have occurred at the patient level? Is there any improvement for that? At the planning level, where the logistics problems were there? What about the learning goals achieved or not? Who takes the responsibility for looking back the suggestions for improvement? So continuous quality improvement is important. Documentation, standards and guidelines to be followed. Safety training, simulation is an effective way to learn about a critical event. Medical safety, you should have a legible prescription and be careful when handling look-alike and sound-alike medications. 5 R's of medical safety, you should get right drug, right patient, right dose, right route, right time, along with right site as the 6th R. Electrical safety, safety fuses with each equipment, no loose wires or connections. It should be properly plugged and fixed. Electricity backup, battery or generator should be there. There should be an emergency exit or fire exit in the building, smoke detectors and water sprinklers on the roof, fire extinguishers in all area, and training in fire management should be done. Mock drill should be done. Then solutions to improve. There should be institution of policy, patient safety committee should be constituted in every hospital. Should develop clear policies and protocols for patient safety. Give orientation for the hospital staff on patient safety. Encourage transparency in regular death review. And review, monitor, and encourage regularly. Every error has a root cause and every cause has a solution, but repeated error is a crime. I think the organizers have selected this topic in the CME because Patient Awareness Week, Patient Safety Awareness Week takes place in March, and this year it takes place in March 12th to 18th. So it's created to encourage education on healthcare safety. Thank you.
Thank you, madam, for the wonderful session on perioperative patient safety, its monitoring and measurements. Madam, as mentioned, like patient safety is not only the surgical safety, but also
It's a shared responsibility.
yes, it's all comes electrical safety and all the measures. And also, madam mentioned about the patient questionnaire, the post-operative that we can do in the post-operative ICU, so that some patients awareness. Some may have awareness of pain and can be, and we can improve the patient safety also. Like, thank you, madam. Thank you. Any questions from the?
Madam, you have given an interesting lecture, completely covered. What I want to inform the audience, what are the things you have mentioned, it is coming under NABH accreditation. So if a hospital is to go for NABH accreditation, everything has to be done what madam has described. And I want to point out only one thing, because it has happened to me. Because in Tamil Nadu, my institution was the first one to go for NABH accreditation in the government setup, and we have followed all the forms. But the preoperative checklist, we are also having this, and we have filled it up. But the non-conformities by the inspectors mentioned, the plan of anesthesia not mentioned. See, routinely in the case sheet, we write fit RAGA, ASA 1, 2, whatever it is. But just because we are following this printed format, our people have ticked without mentioning what is the plan of anesthesia. It is mentioned in the case sheet, but the observer said, this is a non-conformity. So what we have done, we have taken one more copy in the computerized copy, Xerox, and we have submitted as a compliance report. So while preparing the checklist, we are not supposed to miss the basic points. That's what I want to convey.
Any more questions? Okay. So we will wind up the section. Thank you, ma'am. Thank you.